We are so pleased to have Dr. Arielle Heeke with us today. She is a breast medical oncologist at Atrium Health Levine Cancer Center. She earned her medical degree at Emory University, where she also did her internship, and her fellowship was done at Georgetown University School of Medicine. She has spoken at several international conferences and written numerous articles that have been published in oncology medical journals. Dr. Heeke, we are so pleased to have you with us today.
Well, thank you so much for the introduction. I'm very, very happy to be here with you guys, and do want to reiterate that I want this to be as informal as possible. The topic definitely lends itself to a kind of collaborative discussion. So, think of it kind of like a clinic appointment, where you can just, insert a thought or insert a question. Sorry, there's a helicopter going now. Whenever it kind of comes to your mind, definitely don't feel like you need to wait for any sort of pause. Just, shoot the comments out as they come. So let me go ahead and share my screen. Hopefully everyone is seeing the first slide, the title slide. All right, well then we will jump right in. All right, so here's our outline for this evening, looking at menopause and how that impacts patients with breast cancer. So first, very briefly, a definition of menopause. Then we'll kind of get into the meat of our discussion in terms of different symptoms that might come in from natural menopause, but of course, also how are we augmenting that experience with our breast cancer therapies. And then at the very end, I do have a few slides also kind of touching on soy and phytoestrogens and what that means as a individual with breast cancer in their history. So I actually want to pause right at the get-go and try to get a sense of what you might be most interested in discussing today. So if there's anyone that wants to shout out from this list, hot flashes, weight gain, what are some things that have been bothersome to you along your journey? And if not, that's okay too. We'll just keep it moving.
I pretty much have all of them generally. So I'd like to hear. I'm very excited that you're going to speak to a lot of these because, along with the anastrozole, which adds to the fun of it all, and the hair thinning. And I also have hypothyroidism. I just went on levothyroxine like 3 months ago, and my hair's thinning out, and it's a little distressing to have that on top of, the issues with the bone health and I'm on Fosamax and so I'd love you to speak to all that stuff.
Yeah, no, absolutely. It's very difficult sometimes to find that balance where, you obviously want to give someone effective therapy, i.e. the aromatase inhibitor, but you're often having to balance that with all of these side effects that really do impact quality of life. So we will do our best to dive deep into those. All right, so first, a definition. So menopause is permanent cessation of menstrual periods for 12 months without any other obvious pathological or physiological cause. And menopause essentially represents ovarian follicular depletion. And to really confirm with laboratories, we'll often see a low estrogen or estradiol level and a high FSH. Median age of menopause in a normal population is around 51. We do tend to see that earlier for our younger ladies who are diagnosed with breast cancer and go through breast cancer treatments. They do tend to go through menopause a little bit earlier. Hey, Dr. Bailey Dorton. I see you coming. Or she's coming in and out anyways. All right, so symptoms of menopause, we'll go through all of them, but some initial classic symptoms. Firstly, you might notice a change in your menstrual cycles. It's very common to have heavy periods right before your periods stop completely, and irregularity to the periods. Vasomotor symptoms such as hot flashes or night sweats are very common, and changes to the vaginal tissues are very common. Other symptoms that might creep in: sleep disturbance, cognitive changes, kind of losing that mental sharpness is a very common complaint. And then psychological symptoms such as depression and anxiety. So when thinking about menopause and breast cancer, I think it's very important to understand where our estrogen is, meaning, you know, a premenopausal lady still has quite a bit of estrogen circulating in the body, and that's predominantly coming from the ovaries. You know, when thinking about this, I think of a scale of 0 to 100. So, you know, let's say that a premenopausal patient has 100 estrogens, and again, most of this is coming from their ovaries. Conversely, a postmenopausal patient, her ovaries are no longer producing estrogen, but she still has some estrogen in her body. You know, it may not be 100 estrogens, we might be down to about 10 estrogens now. And these estrogens are being produced outside of the ovaries and other tissues, predominantly our fat cells. And that's via an enzyme called aromatase, which perhaps for those of you that are on aromatase inhibitors, you were educated that that's what, you know, these therapies are doing, is they're blocking that enzyme that creates estrogen outside of your ovaries. We do make estrogen in a few other places: our bone cells, vascular cells, liver, and brain as well. But you know, your total amount of estrogen is significantly lower when you're a postmenopausal woman, which, you know, is kind of a no-brainer. Of course, all of our therapies do tend to impact the development of menopause and kind of how our body is experiencing hormones. Chemotherapy is probably the biggest hit to our naturally produced hormones. Very commonly can cause early menopause in our younger patients. If it doesn't cause menopause, you know, right as chemotherapy is administered, it may still, you know, change their natural time frame that they would have gotten menopause. So maybe their periods come back, but they go through menopause at age 45 rather than, you know, that 51 average. And then if a patient is put on endocrine therapy, there are a variety of menopause-like symptoms that can develop. So I'll speak to the aromatase inhibitors first, because we were kind of discussing anastrozole. And essentially, the most common statement that folks make is exactly what you said. Well, I'm already experiencing all this stuff. You know, so a postmenopausal patient is your candidate for an aromatase inhibitor. A postmenopausal patient is someone that perhaps is already experiencing symptoms of vaginal dryness, hair thinning, joint stiffness, changes in energy level. And then now, you know, because they already went from 100 estrogens down to 10-ish, and now we're going to take that 10 down to 0. So whatever menopausal symptoms were happening before, we're going to take that to the max. So menopause to the max. The visual that I think is appropriate, but also really depressing, is a little old lady, you know, getting up from a chair very slowly with her thin white silvery hair. That is essentially what we're asking your body to do with this therapy, is get all the way down to estrogen level of 0. Tamoxifen still lets your body have some estrogen circulating, but it does influence the way that your body is experiencing hormones. So it doesn't cause menopause directly, but it does influence the hormonal balance. And because of that, women will often still experience some of these menopausal symptoms, or, you know, PMS type symptoms. And then, you know, the ladies that sometimes struggle the most with our anti-estrogen breast cancer therapies are ladies that are candidates for what's called ovarian suppression with endocrine therapy. So these are premenopausal patients with, you know, 100 estrogens before they get this diagnosis. And then because of their risk profile, we will sometimes ask them to shut off their ovaries, so to go from that 100 down to 10, and then also, you know, take the pill therapy on top of that. And they can be at highest risk for not only the kind of obvious quality of life side effects, but also some of the more silent side effects like bone loss. Okay, so we will now dive into I was just trying to do a time check also. We will now dive into the different symptoms. So we'll start with hot flashes. So hot flashes are the most common menopausal symptom, occurring in, I'd say, at least half of the patients that take aromatase inhibitors or tamoxifen. Higher frequencies of hot flashes have been reported in women who are obese, are smokers, have reduced physical activity, or are of a certain race, such as African American. In a patient that does not have a history of breast cancer, if they had very debilitating hot flashes, oftentimes or sometimes oral hormones will be used, but of course in a breast cancer patient, we want to avoid that at all costs. So non-hormonal treatments are what we're looking for. And this is kind of the standard list that you've probably come across. We believe that the most effective is behavioral, which is not very sexy, but it just is what it is. You know, hot flashes can come and go pretty quickly, so those behavioral techniques may in fact be the most effective. So lowering room temperature, which is going to make your spouse very angry with you. I have heard of cooling devices that you can put under your I guess mattress or your sheets or something where it just cools you directly. There's apparently a company in Charlotte that does this, and it's this whole crazy system with like water that goes through pipes and goes to this pad in your bed. But the gal that told me about it said it was a game changer for her. So maybe you don't have to get this whole crazy pipe system, but some sort of, you know, cooling system for just you in the bed, so that again, you know, your spouse or your partner is a little bit more kind to you as a result of the room temperature. Fans at work, at home, you know, by your bed, you know, folks are often having to do that a lot. Dressing in layers for your daytime, so you can quickly take off a sweater. Then if you get cold, you know, put it back on. Triggers is very important to be mindful of for what your specific triggers might be. You know, I think anything that stimulates kind of a fight or flight response would be a trigger. So for example, giving a presentation, if I were, you know, perimenopausal right now, I'd be having a hot flash giving this presentation. So, you know, emotional stress, physical stress can certainly bring on a hot flash, but also things that we're eating and drinking. So for some, it's actually sugar. You may, you know, pinpoint certain things that you're eating where you have hot flashes more common. Alcohol, certainly, caffeine, certainly. So, you know, you do what you can to minimize some of those triggers, but, you know, if you need a cup of coffee or a cup of tea every day, you know, you kind of do what you got to do. What are some other things you can do? So vitamin E, the data is definitely not there. You know, the literature doesn't support that this is going to be a game changer, but anecdotally, for some, it really can reduce the intensity of hot flashes. It's probably about 50-50 where this is effective for people. It's not going to make your hot flashes completely go away, but again, it may reduce the intensity and perhaps the frequency as well. The max dose is 800 units in a day, so you can either take that all at once. If you have, you know, predominantly nighttime hot flashes, you could take it before bedtime. If you have hot flashes day and night, you might want to do it 400 twice a day. And I think if you use it for 4 weeks and you really don't notice any improvements, then, you know, you can let it go. And this is just over the counter. I don't know if anyone has tried it, if they want to speak to their experience with it. Okay. Acupuncture, maybe for those on video, have you guys used acupuncture for anything?
I did. I used acupuncture when I was going through Taxol. Mm-hmm. And I actually found it to be helpful. And so I just haven't gone back to like making appointments. I'd heard before about acupuncture for hot flashes and stuff like that. So that's a good reminder.
Absolutely. And we'll touch a little bit more on the literature in a second. But you're right, acupuncture is used for a lot of different things: neuropathy, treatment or prevention, hot flashes, the joint symptoms as well. So we'll touch on that a little bit later in the talk. Mind-body-based therapies or cognitive behavioral therapy are kind of plus minus as well, but they, you know, are available through, you know, our supportive oncology group here. And I would imagine Levine has similar opportunities. Weight loss, if you think about, you know, the fat cells and estrogen, and also just, you know, the stress on your body from that weight, that's, you know, some of the reasoning behind why weight loss can be helpful. Medications are definitely an option. not surprisingly, there's a little bit of resistance to starting medication for this symptom because, you're adding a medication to deal with another medication when we're dealing with menopause symptoms on breast cancer therapies. So this tends to be a little bit of a last resort for folks, but it is an option. And we'll go through some of the data as well as to why these therapies are effective. And then essential oils, I think has come up a little bit more recently. Peppermint oil, maybe, on the back of the neck. I would imagine there's some other essential oils that you could potentially try to see if that helps. And I don't know if anyone has tricks that they want to share that, folks that have struggled with hot flashes. I think a lot of information about some of these menopausal symptoms are, coming out of these support groups and Facebook groups, little tricks that maybe you've heard from somebody else or you've tried yourself. I don't know if anyone has any good experience there. Maybe not, so I'll teach you all my tricks then. All right, so let's go to the fun stuff, medicines, because that's what doctors do is they prescribe medicines, right? So this is, where a lot of the literature stands with hot flash management. I'll start with the SSRI. So this is a group of antidepressants. And as medications go, this is the most effective option with consistent benefit across trials. Different from how these medications work for depression, where often will take weeks to get an effect. Response for hot flashes typically occurs in the order of days. So that's encouraging. Sertraline and fluoxetine, when they've been studied, do not appear to have a significant effect on hot flashes. So favorite options are listed here. Gabapentin is another medication option. This can be particularly beneficial for women who predominantly struggle with hot flashes at night. And that's because gabapentin can be a little bit sedating. There was one study that looked at a high dose of gabapentin, so 900 milligrams. So that would be typically 3 of the capsules. They compared 900 milligrams to estrogen replacement, and they found that essentially hot flash symptoms were similar. But the dosing of gabapentin was limited by headache, dizziness, and disorientation. Usually folks feel a little bit of that with just a 300 milligram dose, and 900, kind of became a problem. And then clonidine is prescribed uncommonly, but, is sometimes pulled on. It can really cause problems with blood pressure if levels get unstable. So usually if we're going to utilize it, we're using a transdermal patch so that there's a sustained release. It's a little bit, plus or minus if it's actually effective for hot flashes, and it does have some unfavorable side effects. So again, this is typically one that we'll pull on last if we've tried some of the other ones first. And either, if someone didn't tolerate the gabapentin or didn't tolerate the antidepressant, because that certainly happens too. And usually when we're considering medications, every patient is different, but usually folks are trying to do the first slide first with, vitamin E, acupuncture, but if that's ineffective, but they want to stay on their breast cancer therapy that's causing, worsening of these symptoms, then they might try these medications. And this slide, if you can read it, shows the relative effectiveness of some of these medications and then some of the other natural strategies. And hopefully you can kind of conclude that each one does offer some degree of benefit, some greater than others, with your medications typically providing the greatest degree of benefit. So clonidine is this bright blue, and then, orange, lime green, light blue. This is the SSRI or the venlafaxine. You can see vitamin E is this kind of yellowy orange, some benefit, not a whole lot. And then some of the other kind of phytoestrogens that we'll talk about at the end. Black cohosh is this navy, and then the green, I guess, diamonds is soy. And these lines are representative of a hot flash score, so you want them to be lower. All right, so shifting into acupuncture. Acupuncture has demonstrated benefit in several randomized clinical trials. I've listed just 2 here. There was one study that looked at acupuncture and self-care versus self-care alone, with significantly lower hot flashes following 12 weeks of therapy, with ongoing benefits for patients that received acupuncture in addition to self-care. Another study looked at electroacupuncture, which is some sort of acupuncture where they apply an electric current between the acupuncture needles. And they compared that to gabapentin and showed that the acupuncture was more effective with less side effects. There was also a study that compared venlafaxine, the SSRI, with acupuncture. Both groups had significant improvements in hot flashes and depressive symptoms, but there were some limiting side effects with the antidepressant group, the venlafaxine group. And then additionally, the acupuncture group reported increased libido, improvement in energy, clarity of thought, and sense of well-being. Any questions about hot flashes? I think that's my last slide for hot flashes. Okay. I gather that folks are eager for information, so I will keep it going. All right, so now let's turn to sleep disturbance. So sleep during menopause and on our breast cancer therapies, that oftentimes it's all happening at the same time, can certainly impact your sleep patterns and your sleep health. Not only can you be having hot flashes at night, but also hormonal changes certainly impact, the ability of your mind to shut off, essentially. So even if you're not overly stressed, your mind just might be going a mile a minute as we're shifting your hormones around. Cognitive behavioral therapy has been shown to be most useful here, different from, hot flashes, for example. This is really the primary space for it. And I included one study here as well that looked at about 250 breast cancer survivors randomized to cognitive behavioral therapy with a therapist, cognitive behavioral therapy alone, or no therapy for 6 weeks. In both groups that got cognitive behavioral therapy reported improved sleep quality. If there's not an interest for cognitive behavioral therapy, maybe there's not time or whatnot, medications can certainly be used as well. We do our best to avoid things like Ambien, but honestly, sometimes that is the only path forward once we've tried all these other things. But things we typically will try first would be gabapentin, especially if there's that hot flash component, SSRI if there's a hot flash component, and or a mood, component in terms of symptoms to the endocrine therapy. And then also an easy thing to do is just to reevaluate the timing of your endocrine therapy. So sometimes switching from morning dosing to nighttime dosing or midday dosing of your aromatase inhibitor, for example, can impact how your sleep quality is. If you're on tamoxifen, you can actually divide the dose into twice daily dosing, and that may impact your sleep quality. So that's kind of an easy, low-hanging fruit. There are natural remedies for improving sleep. Melatonin, of course, we're all familiar with, plus or minus results on that. For some, it works miracles, but for most, it doesn't. And then some kind of newer natural strategies for trying to fall asleep or stay asleep include valerian root and passion flower extract. There is some concern about valerian root and potentially inhibiting the appropriate metabolism of tamoxifen. So if you're considering starting valerian root and you're on tamoxifen, just make sure you talk to your medical team first. And then mind-body-based therapies, yoga, exercise, to try to minimize a stress component if that is contributing. And you can combine melatonin with passion flower extract, for example, to get a more potent effect. Okay, now we'll move on to mood changes. So it's, you almost can't even fit in the slide how much goes on following a breast cancer diagnosis. Not only are you anxious about the treatment plan, in your work schedule. I mean, life is literally already so full, bursting at the seams before you even get this diagnosis. And then trying to, weave in all of the things we're going to ask of you is definitely enough to make somebody break and to make, your family break too. So we have all of that, plus, hey, we're going to, mess with your hormones too with our therapies. And even for ladies with triple negative breast cancer, we're still messing with your hormones because the chemotherapy is going to impact how much hormone is circulating in your body. It's very common to prescribe an antidepressant during therapy. And this, to tie it back to the title of this talk, mood changes certainly go on with menopausal symptoms, but in the setting of breast cancer, there are so many other things that are impacting mood too. So it's kind of just the whole beast. But it's very common to consider prescribing an antidepressant with the idea that it doesn't have to be forever. What's going on is potentially a temporary situation with lots of changes, lots of fears. And so, it might make sense to start something like this now and then, pull off in however many months or years, makes sense. So I've listed on the slide here preferred antidepressants or preferred SSRIs. And the reason why this list is preferred is because our other list, which I'll show you next, is long. And these drugs, we just can't mix with tamoxifen. So it's best if we try to use one of these drugs in this table, just in case we do want to pull on tamoxifen in the future. A lot of these drugs too will help us with hot flashes, with sleep disturbance. So this is a nice list of antidepressants to choose from if that is something that you're open to trying. So going back to our bad list, so tamoxifen, the reason why we can't mix tamoxifen with some of these antidepressants is tamoxifen, when you take it by mouth, is actually not active. It requires the liver to metabolize it to its active form. And that enzyme that metabolizes tamoxifen can be inhibited by the drugs on this list. So this, I'm kind of embarrassed to say, this comes up for me on some regularity where, I've had a discussion with somebody about tamoxifen, I'm putting it in the computer, and then I get a warning, that they're on, some medication that, is maybe not conducive to also starting tamoxifen. And then you're kind of stuck with, all right, if I have a premenopausal lady, for example, are we going to make her postmenopausal to put her on therapy, or do we have to, transition to a different antidepressant, which unfortunately is typically what we do, which really sucks. It takes a while to, find that antidepressant that works for you. Now with aromatase inhibitors, you can do whatever you want with antidepressants. You don't worry about that metabolism issue, but tamoxifen, we just have to be mindful of it. Any questions so far? Okay. Weight gain. So weight gain is definitely something that happens with menopause. So it can be very tricky to really tease out, and certainly breast cancer treatment just in general, but it can be very difficult to tease out once we kind of get to the maintenance endocrine therapy phase, what is from natural aging, natural menopause, what is from stress, from all of this stuff that we've asked you to do, and what is, from the medication. And we can't, the answer is the same, regardless of the source of the weight gain. It's exercise and diet, but I think a lot of folks get discouraged when they start the endocrine therapy and they start gaining weight. They're kind of questioning whether or not to stay on therapy essentially. And I guess all I'm trying to say here is it's multifactorial. There's so many things that have contributed to that weight gain. So to go through some of the text on the slide here, so nearly 80% of patients diagnosed with breast cancer experience weight gain with a range of 2 to 18 pounds. We've definitely seen, probably more than 18 pounds. And the highest risk patients for weight gain during their breast cancer treatment are women who become postmenopausal within 1 year of their diagnosis. As I kind of alluded to, weight gain is a given as we age. So we have those hormonal changes that add weight around the abdomen and hips when that estrogen drops. We have less muscle mass, even if we're working out regularly. And that muscle mass, that decrease in muscle mass is going to decrease your metabolism. And then also naturally, we tend to be a little less active, in part due to that joint stiffness that happens as we age, but also the weight gain. So, you've got the joint stiffness and the weight gain, and it just makes us, a little less active, a little less likely to keep our weight that we had before. Specifically for breast cancer therapies, chemotherapy is the largest contributor to weight gain. Contrary to popular belief, chemotherapy causes weight gain. We usually think of chemotherapy causing weight loss because of, times of nausea and maybe not eating, 3 meals a day, but the kind of unhealthy state that is a person on chemotherapy causes that weight gain, whether it's the steroids or the irregular eating patterns, grabbing, the mashed potatoes because nothing else tastes good, rather than having your, oatmeal in the morning with berries and salad for lunch. You can't keep up with those healthy habits that maybe you could keep up with before. In the initial clinical trials that looked at drugs like tamoxifen compared to placebo, they actually did not report any weight gain. And this was something this was a little before my time. This was back in the 1970s or so. But they apparently were very vigilant about monitoring for weight. They would, measure people's waists. They would get those little calipers and squeeze the fat to really try to see if there were changes in weight. And they did not see any change in weight. These studies were predominantly in postmenopausal women. And tamoxifen, as a refresher, does not make your estrogen level go all the way down to 0. It lets you still have a little bit of estrogen circulating. Maybe that was, part of the reason why they didn't see weight gain. Or again, going back to the idea that there are many different things contributing to weight gain following a breast cancer diagnosis. It's not just therapy. And I hear somebody maybe trying to chime in, or maybe it was just a mute issue. So also, as I said earlier, there's not really a trick to get rid of the weight. You just kind of have to pick up all the things that are very difficult to do, increasing exercise, finding things that you can limit in your diet. And if there is any, consolation for doing that, we do know that a healthy BMI and regular physical activity can reduce your risk of breast cancer coming back. So not only are you working to get back to that healthy person that you maybe were before, but you're also concurrently reducing your risk of breast cancer coming back. Cognitive changes. So memory loss and difficulty concentrating are common when we are depleting estrogen. So that first hit to the system happens with menopause naturally, but we could further exacerbate that problem with our endocrine therapies, and certainly chemo brain with chemo, could also be going on. Other kind of factors that impact your cognition moving forward with your breast cancer treatments are the effects of surgery and anesthesia, especially if you're having multiple surgeries, if there's reconstructive surgery involved. That certainly is going to have some impact, hopefully short term, but there could be some longer term damage from that too. Stress again, and the normal aging process. I worry about memory loss and difficulty concentrating a little bit more in the more elderly population. So ladies that are in their 80s, it becomes a little bit more obvious when you start anti-estrogen therapies that their memory just, takes a dive. But also a high risk group is 50 to 60. These are women that maybe just recently went through menopause naturally. They may still be working, and typically a woman in her 50s and 60s is in a higher level functioning job, maybe a manager, and she really doesn't have the wiggle room to deal with difficulty concentrating or memory loss. I mean, that could really impact her job performance. So that sometimes comes to light where, a woman is like, I can't do this therapy because it's impacting my work, and I've got to keep working for X number of years, and I have this kind of higher stress, higher power job. The good news is it sometimes stabilizes with time, but as menopause and menopause symptoms go, that could be years. So you may not have the luxury of time. There are some ways to intervene. None are a slam dunk, I would say, but nonetheless, they're worth trying. So stimulants are probably the most slam dunk, but this is things like Ritalin. So we try hard not to prescribe things like this because there's a lot of other bad side effects that can go along with it. It has been studied a little bit for chemo brain, and again, it does show effect, but there's cardiovascular problems. You have to be closely monitored by a physician once a month. So again, we try to avoid that if at all possible. Typically, I'll recommend for folks to pick up an exercise routine. This kind of gets the juices flowing, makes you feel good about yourself, and can push you forward out of the slump. Restorative sleep is important. Ginseng is for fatigue, but I kind of added it to the slide because I didn't really have another great place for it. I've seen radiation oncology actually recommend this recently for radiation-induced fatigue, but it's certainly something you can try outside of the radiation setting.
Excuse me, Dr. Heeke. Yeah, I was on that for radiation during my radiation time. The question I have is, if I recall, at the time, now this would have been, I'm a year out from radiation, or a year and a half. So this would have been 2019. Mm-hmm. I didn't stay on it long after, it was just for that time period. Yeah. And it wasn't recommended to stay on. I mean, it did help. I guess it helped. You know what I mean? It didn't hurt me. I was very tired, but I had gone through chemo and surgery and that, but so that was my question. I mean, can you stay on it for a long time? What are the side effects of that if you do that?
Yeah, my understanding is that it actually wasn't studied for radiation-induced fatigue. It was just kind of studied for generalized cancer treatment fatigue. Okay. My answer, without fully knowing how to answer your question, is yeah, I think it's fine for you to continue to take it. It doesn't just have to be, I don't know how many weeks or months they told you to take it after, I'm assuming after radiation completed is
I started it during radiation. I just forget how far into. I had 6 weeks, and then I stayed on it for a number of weeks after and then stopped. I just don't remember how long it was.
As far as I know, there's not any side effects to it. I mean, it is pricey, so you have to get the pure Wisconsin, right?
I ordered it off of Amazon. Yeah.
So that's, maybe a limiting factor is just the cost. You can't get it. There's some issues with how it's manufactured when you don't get the pure ginseng. But again, as far as I know, there's not any side effects to it.
Okay. Thank you.
And then the last comment here, and perhaps the most helpful, is we have a neuropsychologist at Atrium or at LCI. Again, I would assume Levine probably has similar opportunities or wherever else you're getting treated. So Dr. Hartzell, she will perform a several-hour examination with you to try to better understand what is causing your cognitive decline. Is it inattention? Is it memory issues? And once she's kind of diagnosed those things for you, albeit, hopefully temporary issues, then she can start to give you strategies about how to overcome those symptoms. She can't necessarily fix the symptoms, but strategies to overcome them. For example, if you're struggling with inattention, she might, give you strategies for not multitasking and kind of how to manage your day with that inattention issue. So if that's something that you're interested in, and you've got a provider at LCI, we can certainly make that referral for you. Okay, then we will move into joint symptoms. I fear I'm going to run over here. I apologize, because we still have a lot of goodies to get to. All right, so joint symptoms, otherwise called arthralgias, are most common with aromatase inhibitors, but they can also occur with tamoxifen. And there's a aromatase inhibitor associated musculoskeletal syndrome that includes the arthralgias, so that's like the pain, but also joint stiffness, and then you can have pain in the bones as well. Carpal tunnel actually comes up a lot with aromatase inhibitors. It's not, it's not really an arthralgia per se, but we hear all the time that carpal tunnel starts flaring, or like a trigger finger will develop on aromatase inhibitors, and it has something to do with the lubrication or lack thereof in that wrist joint, and how that could be influencing your carpal tunnel. These symptoms may be self-limited, may improve over time without intervention as your body adjusts to kind of this new norm. But again, you may not have that luxury of time. These symptoms may, take a year or two, to fully stabilize. For the lucky ones, it might be, 6 weeks or 3 months, but, I think for most, it takes a lot longer for the body to really adjust to the new norm. Arthralgias or joint symptoms impact quality of life in approximately 1/3 of users of endocrine therapy, and can lead to discontinuation of therapy in 10 to 20%. Fortunately, when the therapy is discontinued, typically symptoms are relieved within 2 months. That comes up pretty frequently, where folks will call in with, horrible joint symptoms. They're not able to do what they want to do. We tell them to take a drug holiday, for a minimum of 4 weeks, and typically symptoms will improve. So what can we do about the joint symptoms? Probably the easiest thing is take medicine again. So anti-inflammatories are typically the most effective medicine for the joint pain symptoms. But we don't really want you to take ibuprofen every day. If you're needing to take ibuprofen or something similar every day, then we probably need to evaluate the therapy altogether. Things you can do that aren't ibuprofen include exercise. So I've included here results from the HOPE trial, where patients with arthralgias from endocrine therapy were randomized to an exercise regimen or not, and those that did the exercise regimen reported reduction in pain severity. Duloxetine is another medication that can be considered. I honestly have not prescribed it for this indication. I've occasionally done it for neuropathy. The other name for duloxetine is Cymbalta, but it has been shown to improve joint pain compared to placebo. There are other things you take by mouth, medicines, but they're more natural medicines that you can consider. Turmeric, we recommend often. Haven't really found it to be horribly effective. I've found vitamin E to be more effective for hot flashes, and I've found turmeric to be effective for the joint symptoms. But turmeric and fatty, omega-3 fatty acids are natural anti-inflammatories. You do typically, at least for the turmeric, have to take a high dose. So you can't just, put a little turmeric in your dinner. You'll have to go out and buy a high dose supplement of turmeric. It's recommended to do at least 500 milligrams twice a day, but you probably should take it 3 times a day. Tamoxifen, because of that metabolism issue where it needs to get metabolized into its active metabolite, you do have to have some caution with these more natural remedies, turmeric in particular. And I've had some discussions with Dr. Bailey Dorton on this offline. I don't know if she's still on, so we'll see if she wants to chime in. High doses of turmeric can inhibit tamoxifen metabolism as well. In general, 500 milligrams twice a day or 3 times a day is probably okay if you're on tamoxifen, but if you have another option for arthralgia management, that would be preferred. And then lastly, vitamin D. This is a little less established as an indication for arthralgias, but there have been some studies that have shown low vitamin D levels correlate with more aromatase inhibitor arthralgia symptoms. And also in studies that have administered a high dose vitamin D to ladies that are taking this therapy, they tended to report less arthralgia symptoms. And acupuncture comes back again. Acupuncture, we love it for everything. And it has also shown benefit for management of arthralgias. This is just one study. There's a few out there. But this study showed acupuncture for 6 weeks led to significant improvements in joint pain and stiffness. And as is true for, most kind of alternative therapies, we don't fully understand in Western medicine how they work. But perhaps acupuncture increases opioid peptides and anti-inflammatory cytokines. Okay, then we're going to move into bone health. So the biggest, change for bone health is going through menopause. So whether that happens naturally or, in your breast cancer journey, if you're asked to become postmenopausal for risk reduction, that's going to significantly hurt your bone health. So estrogen normally inhibits bone breakdown, and our bone loss can be very pronounced with a sudden and severe estrogen depletion, which could occur again for that young patient that is being asked to, suppress her ovaries plus, potentially take chemo plus take these, pill-based endocrine therapies. But we do, of course, have to worry about our naturally postmenopausal ladies too. This is the bigger bulk of where we're monitoring for this side effect, because those postmenopausal patients are typically being recommended to take an aromatase inhibitor. So when you go through menopause, again, you go from 100 estrogens down to 10, let's say, and then we do the aromatase inhibitor, it takes it down to 0. And all of those changes in your estrogen in your body are going to lead to bone loss. So several studies have looked at this. One study demonstrated that patients experienced a 5 to 6% worsening in bone health compared to patients on tamoxifen when they were taking an aromatase inhibitor. In premenopausal patients, when they get that whole shebang of ovarian suppression, et cetera, they experienced a bone loss of 17.3% at 3 years in the aromatase inhibitor treatment group compared to 11.6% in the tamoxifen treated group. And tamoxifen, I don't think I've really made this clear. Tamoxifen lets your body still have some estrogen circulating. It just doesn't let the estrogen get to breast cells. So for a postmenopausal patient that's taking tamoxifen for whatever reason, maybe side effect profile or personal preference, that estrogen that's no longer going to the breast cell is now kind of shunted to other places. And one of those places is bone. So that estrogen is now going back to the bone, which is a good thing for bone health. So what do we do about this? This is actually a major area of concern that the medical oncologists have. We don't tend to really share it with you because we kind of have to guide you with, managing the worst evil, which is of course cancer. But we really worry about this for all of our patients, not just the young ones. We try to monitor your bone health regularly. So if you're going to start an aromatase inhibitor, we'll typically monitor your bone health every 2 years. But sadly, once you graduate from our clinic after a few years of follow-up, if you have, the ability to do so, we're not tracking your bone health anymore. And that's really when it potentially becomes a problem, is when you're back in your, primary care space. So you just have to remember to make sure you're getting your bone density study every couple of years. That's standard of care, for a woman that's 60 or older, is to get a bone density every 2 years anyway, but it doesn't always happen unless you're, also thinking about it. So in addition to monitoring, there are things that you can try to do to intervene. So non-medical things include weight-bearing exercises, so regular walking, yoga, actual things with weights are very helpful. My bad visual for this is People that actually have the healthiest bones are people that have a lot of weight on them, because their bones are being asked to withstand that weight. So that's why weight bearing exercises are helpful. Smoking and thyroid disorders also impact your bone health. And alcohol can also negatively impact your bone health. So you want to limit that as possible. When we start somebody on an aromatase inhibitor, we'll typically ask you to take calcium and vitamin D as well, a little bit higher doses than maybe in your multivitamin. And then depending on your degree of osteopenia or potentially osteoporosis on your DEXA scans, we may even recommend that you take a bone strengthening medication that's IV or shot, or even the oral, like the Fosamax. The bisphosphonate therapy does also have some risk reduction benefit for breast cancer. So if you are, offered that therapy because there's a concern about your bone health, do know, that it's also helping reduce the risk of breast cancer coming back. It's a very small benefit, so we don't offer it to everybody because there are some drawbacks to bisphosphonates, but it is.
So you're not telling me that I can have alcohol in place of, since I'm taking the,
Great.
I'm just saying, just kidding.
Everything in balance, but there are other issues with alcohol, just in general. So
understood. Yes.
we want to limit alcohol. We're not going to send the police on you, but I think a good rule of thumb is, honestly, if you can abstain, that's the best. Not all of us can do that, including myself, but if you can limit it to maybe, 2 or 3 drinks a week.
Yeah. Yeah.
Okay. Hair thinning. And then we'll get to the vaginal dryness and sexual dysfunction. I saved the best for last. Hair thinning. This definitely happens with menopause, definitely happens with the anti-estrogen therapies. Estrogen is, our beauty hormone. I didn't talk about skin stuff here because there's not really a whole lot to add, but when we deplete the estrogen, our hair thins out, our skin gets dry, all of our beauty features can be hurt. So when a woman experiences hair loss, typically we'll recommend kind of generic over-the-counter stuff, collagen, biotin. I don't know that I've ever seen it actually help anybody, but it's a place to start. If you want to jump to the next thing, you don't want to mess around with vitamins, or let's say you've done the vitamins for a few months and haven't seen an effect, then typically the next step is actually going to be Rogaine. If we were to refer you to a dermatologist at that point, before you did Rogaine, that's typically what they're going to tell you is to use Rogaine. Rogaine has some direct effects on the hair follicles, but it does take some time for you to see that effect. It usually takes 4 or 5 months to really notice some improvements in your hair thinning. And it's recommended to actually use it for up to a year before it's considered a failure. If you try Rogaine and it is ineffective, then it would be appropriate to see a dermatologist and see what other options there are. For hormone causes of hair loss, some of the other fancy things that they can do in dermatology typically don't apply. Like sometimes they'll inject steroids and all kinds of stuff for like autoimmune type conditions, but typically for hormone induced hair loss, there's not a lot they can do other than give you hormones, which is not what we want to have happen. But Rogaine is reasonable to try. Spironolactone is a medication that comes up occasionally with this hair loss issue. And I'm not a huge fan, although, the data that's available doesn't actually suggest that it increases your risk of breast cancer coming back. The reason why I'm not a huge fan is I believe it probably works by having estrogenic effects in the body. And really the reason for that is back in internal medicine days, so I had to do that training before oncology training, we were taught that men that take spironolactone, so it's actually a medication for blood pressure, we were taught that men who take spironolactone, you have to counsel them that they may develop breast tissue, which to me means, okay, there's like an estrogenic effect happening the breast cells are being stimulated by the spironolactone somehow. So, you know, I'm not a huge fan of it. Patients that have done it have had effect in their hair thinning. So where I've kind of resorted to it is if a woman is really having, you know, major quality of life issues with her hair thinning, and has tried all these other things and nothing else works, and she's willing to absorb a small possible risk, you know, for that gain, then I'll back her. But we do have a discussion about it. Any questions about that? All right, so then we will close with, we'll almost close with some discussions about vaginal dryness and sexual dysfunction following menopause and our breast cancer therapies. So vaginal dryness, our vaginal tissues are estrogen dependent tissues, and as we deplete the estrogen either naturally through menopause or not naturally through our breast cancer treatments, there's going to be thinning of those tissues, and that thinning can cause symptoms of vaginal dryness, itching, and painful intercourse. There are a lot of things that you can do for vaginal dryness, and the very last resort is kind of similar to that spironolactone discussion, where there is a hormone option, but we try to save it to the very, very end if we can. So typically what we want you to start with is a regular routine for topical moisturizers and lubricants. So the moisturizers are kind of the regular use option, and then the lubricants is for sexual intercourse. And it's recommended actually to use the moisturizers nightly for 12 weeks. And then you kind of use it as needed to really give the tissues a chance to beef up again. So this is a nice list that Dr. Bailey Dorton has shared with us at LCI of some more creative options for topical moisturizers, and they're very genius, I think. So thank you for sharing that. So first one is sea buckthorn oil. Has a high content of omega-7. It supports mucous membranes, prevents them from becoming dehydrated. And there was a study that showed that it improved the integrity of the vaginal epithelium. There's vaginal pH balanced gel products. These are useful because low levels of estrogen lead to an increase in vaginal pH, which then can lead to symptoms such as dryness, itching, and burning. And when you apply a pH balanced gel, there can be improvements in the dryness and that painful intercourse following breast cancer therapies. Hyaluronic acid vaginal gel. So hyaluronic acid sometimes is used in kind of joint replenishment. So it kind of makes sense how you would use it in other tissue replenishment. It has hydrating properties. It acts as a lubricant by releasing water molecules into the tissue. And trials have also shown that it performs similarly to estrogen cream. And then you kind of have your run-of-the-mill, over-the-counter moisturizing gels that are not hormonal. So Replens is typically what we'll recommend for patients up front that are struggling with this issue. That's the moisturizer that's been studied the most. But there's other options, Astroglide, KY, these are all probably names you're familiar with. But again, to really get the effect from this therapy, you need to do it regularly. So nightly for 12 weeks. It's recommended to do it nightly just to make sure that the product actually kind of stays inside you. So gravity is your friend rather than having it, come out on your underwear as you're going about your day. And then lubricants are predominantly used during sexual intercourse. There are, over-the-counter lubricants, but then there's also, natural lubricants that you can consider. Vitamin E vaginal suppositories have become popular, but you can also just go in your pantry and pull out some olive oil. If you have tried a pretty consistent routine of moisturizers and lubricants and still, you're having some problems, and this, can really affect your personal life, this vaginal dryness and also libido. So if you've tried the moisturizers and lubricants, still having problems, then we might discuss a procedure to help with vaginal rejuvenation. So two that are out there include Mona Lisa, and I think it's I don't know how to say the other one, Thermiva, I don't know. They are limited by price. So if you don't have $3,000 hanging around to pursue these therapies, and this may not be a step you can pass through. They essentially involve a probe that's inserted into the vagina that delivers some sort of therapy. So the Mona Lisa is a CO2 laser. The Thermiva, or however you say it, is a radio frequency energy, and they both work to stimulate collagen production within the vaginal tissues. They do tend to be relatively effective. It's not 100% effective though, so there are certainly women that may spend their $3,000 and not achieve effect, but it's at least a 50-50, if not a little bit more. And I put here, so the Center for Women's Aesthetics in Charlotte offers the Mona Lisa, and then there were a couple of plastic surgery offices that offer the Thermiva. And then lastly, so if you try the moisturizers and lubricants and don't have effect, and maybe try the procedures, or maybe you don't because it's expensive, then the next step would be doing some sort of topical hormone. Intra Rosa is a topical hormone that I think gynecologists are starting to recommend a little bit more because it's not actually topical estrogen, but it probably does still lead to some level of disruption of our whole body estrogen. So in some of the studies, there were increases in the hormone DHEA, which is what it actually is. So they picked up DHEA in the systemic or whole body circulation, as well as testosterone, and slight increases in estrogen or estradiol as well. So I don't know that it's really much better than the next bullet point, which is topical estrogen. So I don't really feel strongly that someone needs to do Intra Rosa over topical estrogen if they're now at that need for something topical. The topical therapies are very effective. Pretty much as soon as you start using it, your symptoms go away. So we hate to kind of hold out the M&M until the very end, but the concern with even a topical therapy is that there is going to be some level of estrogen getting into the whole body. So for a woman that's on an aromatase inhibitor, for example, her whole treatment plan is reliant on her estrogen level being 0. So if we're potentially putting some more estrogen back in there into the whole body circulation, she doesn't have a line of defense against that. Tamoxifen, if a woman's on tamoxifen, she could theoretically block that estrogen that's now gotten into the whole body circulation. But so as to not poo-poo aromatase inhibitors too much, we also know that aromatase inhibitors are more effective in reducing the risk of breast cancer coming back than tamoxifen in a postmenopausal woman. So we still like to use aromatase inhibitors, and more just bring up this point: if you're at a critical point with the vaginal dryness where you're having to use the topical estrogen, maybe that's something you want to have a discussion with your oncologist about. Okay, is everyone still doing okay? I don't normally talk this much, so I'm sorry. All right. I only have, I think, 8 more slides, so we're getting there. So we'll move into sexual function, or dysfunction rather. This is also multifactorial. Libido definitely goes down with natural menopause. Libido is going to go down as we're messing up your hormones with the chemotherapy and anti-estrogen therapy. There are anatomic changes, not only the vaginal dryness and painful intercourse that's certainly going to limit your desire to have that intimacy, but also the vagina can become shorter and narrower during that kind of dryness and less lubricated state. Stress, going back to that picture of the woman with all of the different bubbles around her face of all the things she was stressed about in the setting of a breast cancer diagnosis, definitely is going to impact your desire for intimacy. And just to put some numbers on it, in one study that looked at exemestane, which is an aromatase inhibitor, loss of libido occurred in a third of patients treated with exemestane and a third of patients treated with tamoxifen. So what do we do for sexual dysfunction? Interestingly, I actually uncovered this while putting the talk together. Wellbutrin can improve sexual desire. So Wellbutrin is an antidepressant. Typically, we think of antidepressants actually negatively impacting libido. So this may be a little nugget to keep in your brain if this becomes a problem for you. Wellbutrin we cannot mix with tamoxifen, just FYI. And it may not have as many improvements in terms of the hot flash symptoms. Topical stimulants can be helpful here. There are some that have niacin in them that can kind of bring on that rush of your body, but that's only going to be useful kind of in the moment rather than really stimulating that baseline libido. Body image definitely comes up for ladies that were treated for breast cancer, you know, whether their breast, you know, looks deformed after treatment, or they've gained weight, or, you know, hair issues, skin issues, et cetera, et cetera. So it may be helpful to meet with a psychologist to improve body image. There's also, of course, sexual therapists too. I put here Sarah Galloway. She's one of our psychologists that has a special interest in body image for breast cancer patients. You know, if that's someone that you would like to meet with, just mention that to your oncologist. There are all kinds of practices out there that are interested in kind of improving overall wellness for women, and they often will offer bioidentical hormones or other kind of hormone repletion to rebalance things once a woman goes through menopause, and we want you to steer clear of those, hopefully for obvious reasons. And then additionally, there's a lot of supplements for menopausal symptoms that I also typically counsel folks to stay away from, because there's conflicting data here, but generally speaking, those components in these herbal supplements probably have estrogenic effects. If they're actually improving hot flashes or actually improving libido, then I worry that they could be impacting a breast cancer cell. So very briefly, bioidentical hormones. These are hormones with the same structure as a hormone that is produced from the body, but we really don't have evidence that they are effective or safe. So we certainly want to avoid them in a breast cancer setting where hormones are unbelievably important, and we're trying to block that process as much as possible. And then I'll close with just a little bit on phytoestrogens, with a caveat that I tend to be a little bit more strict here than others. You know, the overarching consensus is actually that phytoestrogens are probably fine. I just still counsel people to try to be a little bit careful with them. So phytoestrogens are essentially plant-based molecules that may have estrogen-like properties or may stimulate estrogen receptors. And one that comes up a lot is soy. You know, is soy okay to eat, or is soy okay to drink? And soy does contain several phytoestrogens. The phytoestrogens, or the isoflavones, which is just another word for a type of phytoestrogen, the content varies widely, with the highest concentrations being in fermented soy. And then soy supplements also may contain very high concentrations of isoflavones. And studies that have looked at using soy to improve menopause symptoms have demonstrated a modest response at best, which again points to there may be some level of estrogenic activity. This is a table that I'll sometimes pull up when I'm having a discussion about soy. It's from a random website called Superfoodly, so probably not the most, you know, legit, but I just like the way that the data is presented. And it's just showing foods high in phytoestrogens. And I show it just to point out, really, you know, phytoestrogens are in a lot of our healthy foods, our nuts or veggies, but really the two things you just have to watch out for are flax seeds and soy. So, flax seeds and soy have a lot of other health benefits. Particularly for flax seeds, folks have been adding it to smoothies, to, their yogurt. And while that, I hate to take away the good health benefits from that, I still have a worry for a breast cancer patient, especially a hormone-driven breast cancer patient, that maybe they should just peel back a little bit on the flaxseed. You don't need to be picking the flaxseed off your multigrain bread, but maybe just not adding it to your smoothie and your yogurt every morning. And same thing with the soy. It's okay to, have tofu occasionally. It's okay to have soy milk occasionally, but, maybe don't have a glass of soy milk every morning and, tofu for lunch. In moderation, is the goal. But the data has really been all over the place. And again, the consensus really is that it's okay, but I just tend to fall a little bit more conservatively with this. So my kind of takeaway with it is that for someone that has been raised on soy, so they've looked at this quite a bit in women in China who have a very high soy intake from an early age. They found that soy intake was actually protective rather than harmful. Conversely, for example, an American population where soy kind of came in vogue more recently, in one small study, for example, at Memorial Sloan Kettering in New York City, increased soy intake, which was roughly 4 cups of soy milk a day, was associated with an upregulation of proliferation genes in women with breast cancer. And in some of the kind of lab-based models of soy, there also has been this, concern about how it might overstimulate a breast cancer cell. But in general, thought leaders, people that we listen to have said it's okay, to do soy and other phytoestrogens in moderation, but maybe to avoid supplements where there might be a super high use or super high dose of the isoflavones or of the phytoestrogens. And then this is my last content slide about black cohosh, because this comes up quite a bit for managing hot flashes. Really, the main thing here is that it might interfere with tamoxifen. So be wary if you're on tamoxifen with black cohosh. And also it's has that potential for estrogenic effects. It's a, phytoestrogen. And the studies that have looked at it for managing menopause symptoms really haven't shown a significant benefit. So that's it. Questions, comments?
That was a wonderful overview of menopause. Thank you so much for all the time you put into those slides.
Absolutely.
It was terrific. Who has questions? Comments or questions?
Everyone's just really excited about their breast cancer side effects.
Menopause is a very exciting topic.
Yeah.
Well, I don't want to be the one asking all the questions because I've interacted a little bit already, but I did hear that soy isolate was the thing to really watch out for, like in protein bars and things like that. Are you aware of that? Is that or do you believe it acts the same as soy?
I don't know the answer to that. I can look into that more. I'm not sure. I mean, I think in general, I guess a soy isolate might be a higher potency. This may be part of the...
Maybe part of a thing, yeah, because they're found in protein bars and stuff like that. So I was just wondering, because they're my favorite things. And, if I'm having something like that, so I'm trying to,
maybe in moderation.
Yeah. And the flaxseed was the first time I've heard that. So my question is, so if flaxseed's not a winner, how about wheat germ in place of flaxseed? Or I know that's an old school that kind of came out before.
Mm-hmm.
Oh, it's not, I don't know if it's on this because I can always look it up myself, but.
I know. I think as far as I know, wheat germ is fine. And really, I really only worry about the top 3, top 4.
Gotcha. Okay.
Flaxseed is like 400,000, and then you get down to, 5, and it's 18,000.
Yeah, that's amazing. Yeah, that's new. That was very new to me to hear.
Anybody else have any questions? Dr. Heeke, thank you so much. This was terrific.